Good morning and welcome to my lecture series on challenges in anesthesia. Laparoscopic cholecystectomy in the patient with pulmonary hypertension. A 45-year-old female patient is scheduled for laparoscopic cholecystectomy. 1 week ago, she had acute cholecystitis that required admission to the intensive care unit for hypotension. She had a similar episode 2 months ago. Her medical history is significant for pulmonary hypertension. What is the approach to perioperative management? In 1973, when the World Health Organization organized the first international conference on pulmonary hypertension, there were no effective therapies. The median survival for patients with primary hypertension, pulmonary hypertension, now termed as idiopathic pulmonary arterial hypertension, was under 3 years. Today, there are multiple therapies and survival has more than doubled. As a result, more patients with pulmonary hypertension undergo anesthesia and surgery. Pulmonary hypertension markedly increases the morbidity and mortality among the patients undergoing surgery. Successful management involves 5 steps. Number 1, diagnosing pulmonary hypertension and its etiology. Number 2, assessing the severity of the disease. Number 3, assessing the risk and benefits of anesthesia and surgery. Number 4, developing an anesthetic plan. Number 5, managing the perioperative complications of systemic hypertension and right heart failure. Diagnosis and evaluation of pulmonary hypertension. Understanding the pathophysiology of pulmonary hypertension allows accurate risk assessment, optimization prior to surgery, and rational intraoperative and postoperative treatment. The pulmonary circulation is normally a low pressure, low resistance circulation. In patients with pulmonary hypertension, altered vascular endothelial and smooth muscle function lead to vasoconstriction, localized thrombosis, and vascular growth and remodeling. These processes increase the pulmonary vascular resistance. The normal thin-walled right ventricle decreases the stroke volume in response to increased afterload. So, pulmonary hypertension can result in right ventricular failure, systemic hypotension, and death. Now, approach to the perioperative management of pulmonary hypertension. Diagnosis and evaluation of pulmonary hypertension. Assessment of the severity of pulmonary hypertension. Assessment of the risk and benefit of anesthesia and surgery. Development of an anesthetic plan. Choice of general versus regional anesthesia. Monitoring. Induction of anesthesia. Maintenance of anesthesia. Emergency issues, post-operative management, plan for treatment of systemic hypertension. The diagnosis of pulmonary hypertension is usually suspected either from the symptoms or from associated diseases that increase the risk. Patients with pulmonary hypertension have three major symptoms. 1. Exertional dyspnea. 2. Chest pain. 3. Syncope. Suspicion of pulmonary hypertension should prompt the evaluation with ECG for right ventricular hypertrophy and right ventricular strain, and echocardiogram, that is right ventricular hypertrophy, enlargement and decreased systolic function with elevated right ventricular pressure by Doppler. pH is confirmed, that is the pulmonary hypertension is confirmed by right heart catheterization. In 2008, the 4th World Symposium on Pulmonary Hypertension reviewed classification, diagnosis, evaluation, and therapy of pulmonary hypertension. Pulmonary hypertension is defined as a mean pulmonary arterial pressure more than or equal to 25 mm of mercury at rest. An approach to understanding the pH is derived from the equation of PVR, that is pulmonary vascular resistance. PVR is equal to pulmonary arterial pressure minus lap, that is left atrial pressure, multiplied by 80 over cardiac output. Rearranging this equation for PAP, pulmonary artery pressure, demonstrates that PAP is equal to left atrial pressure plus cardiac output multiplied by PVR over 80. Thus, the three factors that increase the PAP, the pulmonary arterial pressure, are left atrial pressure, LAP, cardiac output, and number 3, pulmonary vascular resistance. Perioperative therapy requires assessing the quantitative contribution of each component. For example, pulmonary vasodilator therapy will only be appropriate when pulmonary hypertension is associated with increased pulmonary vascular resistance. In patients with pulmonary hypertension, analyzing whether cardiac output remains normal or is markedly decreased has prognostic value in assessing the perioperative risk. The current classification of pulmonary hypertension involves 5 major categories. Number 1, pulmonary arterial hypertension. Number 2, pulmonary venous hypertension. Number 3, pulmonary hypertension associated with disorders of the respiratory system and or hypoxemia. Number 4, the chronic thrombotic and or embolic disease. And number 5, PH, that is pulmonary hypertension due to disorders directly affecting the pulmonary vasculature. The above question for pulmonary arterial pressure can be used to classify the common etiologies. The increased left atrial pressure includes left ventricular failure and valvular heart disease, particularly mitral stenosis. Increased cardiac output includes patients with congenital heart disease with cardiac shunts. Major categories of chronically increased PVR are pulmonary disease, parenchymal or airway, hypoxia without pulmonary disease, that is hyperventilation syndromes, high altitude, pulmonary arterial obstruction, thromboembolism, and idiopathic, that is primary pulmonary arterial hypertension. In addition to this etiology of chronic PH, that is pulmonary hypertension, acute increases in PVR may result from hypoxia, hypercarbia, acidosis, increased sympathetic tone, and endogenous or exogenous pulmonary vasoconstrictions such as catecholamines, serotonin, thromboxane, and endothelin. Most perioperative patients with decompensated pulmonary hypertension have a combination of chronic pulmonary hypertension with an acute increase in the pulmonary vascular resistance. In general, therapy is directed at reversing this acute increase in PVR. Evaluation of the patient with pulmonary hypertension should determine the underlying etiology and severity of the disease. In patients without an identified etiology, ventilation perfusion lung scan should be performed to exclude the chronic thromboembolic PH, that is pulmonary hypertension. Since patients with this disorder should be considered for surgical thromboendarterectomy. Echocardiography with Doppler measurements can determine right ventricular function and right ventricular systolic pressure. Okay, we come to the end of this lecture series now. I will come up with the next lecture in the next video. Thank you.